All right, everyone. It's 12:30, so we're going to go ahead and get started. Welcome to our South Texas Regional Family Medicine Grand Rounds. Our educational partners today are the South Central Area Health Education Center, and our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. This presentation today is only eligible for AAFP CME. So AAFP members, please use your AAFP login to claim credit for this activity at the link on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the AAFP. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Our Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. And now Dr. Shi is going to introduce our speaker for today.
It's my honor to introduce our guest speaker, Dr. Lauren Hughes, is also our guest for the Primary Care Week. So everyone here knows about Primary Care Week. We have, once a year. So Dr. Hughes comes to us from the state of Colorado. And I was reading her resume and CV. It's very impressive. So it's going to take me a while to go through them all. Okay. And she's the state policy director of the Farley Health Policy Center and associate professor of family medicine, both at the University of Colorado. In these roles, she leads initiatives to generate and translate data for policymakers to inform the design and implementation of evidence-based health policies that strengthens primary care infrastructure, improves rural health delivery, and integrates behavioral health and primary care. Dr. Hughes previously served as Deputy Secretary for Health Innovations in the Pennsylvania Department of Health, where she launched the Pennsylvania Rural Health Model, a new payment and delivery model that transitions rural hospitals from fee-for-service to multi-payer global budgets and transforms how they deliver care to better meet community health needs. She also oversaw the launch of prescription drug monitoring program and led the department to full accreditation through the Public Health Accreditation Board. Dr. Hughes serves as chair of the American Board of Family Medicine Board of Directors from 2022 to 2023 and is an alumni of Robert B. Robert Wood Johnson Foundation Clinical Scholars Program. She currently serves as the Vice Chair of the Rural Health Redesign Center Organization Board of Directors and is a director for the American Medical Student Association Foundation. She has been a visiting scholar at the CMS Innovation Center, the Commonwealth Fund, the Robert Graham Center, and the ABC News Medical Unit, and intern for former Iowa Senator Tom Hockin. In 2018, she was honored as a Presidential Leadership Scholar by Presidents Clinton and Bush. And in 2021, she was named to the Board on Health Care Services in the National Academies of Sciences, Engineering, and Medicine. Since August 2023, Dr. Hughes has co-chaired the Standing Committee on Primary Care alongside Dr. Mary Wakefield, also within the National Academies. So without further ado, let's hear from Dr. Hughes. Thank you.
All right, good afternoon, everybody. Can you hear me okay? Okay, wonderful. So back row, Regina, you're responsible. If for some reason my voice trails off and I need to project more, just give me the thumbs up, okay? Fantastic. So good afternoon again. It is my pleasure to have been here the last couple of days as part of National Primary Care Week. Looking forward to talking today about interprofessional teams, team-based care being kind of the focus of your National Primary Care Week sort of activities. I do want to mention that I do not have any financial relationships with any ineligible companies that I would need to disclose. So learning objectives for today, we will talk about the evidence supporting interprofessional primary care teams, describe potential ways to structure and finance primary care teams, discuss changes in education and training required to support more widespread use of teams, and highlight research needs to inform future policy change that improves the quality, sustainability, and effectiveness of primary care teams. So let me start first and kind of anchor us in a seminal consensus study, in my opinion, that came out in May 2021, released by the National Academies of Sciences, Engineering, and Medicine. This report here is entitled Implementing High Quality Primary Care, Rebuilding the Foundation of Healthcare. And I want to mention, and before I forget, that my citations for today's talk, unless otherwise specified, are rooted in this particular report. So starting first with the definition of high quality primary care as described in this report, is high quality primary care is the provision of whole person, integrated, accessible, and equitable healthcare by interprofessional teams who are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships with patients, families, and communities. So this report had 5 major objectives. This is the top line for these objectives. Each of these have several different actions and sub-actions underneath each of them. But the 5 major objectives are focusing on improving payment and access, as well as workforce, digital health, and accountability for implementing high quality primary care. Today in the talk, we'll mostly focus on workforce. So objective number 3, a little bit of payment, objective number 1. Another definition that I would like to share up top in our time together is the definition of a team as described in this NASM report. And it is as follows: the provision of health services to individuals, families, and or communities by at least 2 health providers who work collaboratively with patients and their caregivers to accomplish shared goals within and across settings to achieve coordinated high quality care. So at least 2 or more is how the NASM consensus study authors viewed a team. So are you medical students, residents, a mix, all residents, residents? Okay, fantastic. Who are first years? Raise your hand. Okay, couple first years, second years. Wonderful. Third years. Okay, well, that's a good balance. Okay, very good. So in your clinical training, you are probably being exposed to and exploring different practice patterns and settings and sometimes some stresses that are faced in your respective clinics. In my career to date, there have been a lot of changes at that frontline practice level that, from my perspective, make it difficult for one person to quote unquote do it all. And this is not an exhaustive list, but these are some of the changes that I have seen in my career that set up patient care to be well served by an interprofessional primary care team. The first being HRSNs, or health-related social needs, also known as social determinants of health. And I've really become much more aware of those social needs of our patients and how that impacts their access to care, their quality, and just their overall state of wellness and well-being. Value-based care. We are slowly making policy and changes, moving away from fee-for-service to a value-based or value-driven healthcare system. And primary care is caught up to different degrees within that transition. A lot of administrative tasks in medicine. So you've been engaged in, writing notes and learning about some billing and all the forms and paperwork that our patients come in and need our assistance to complete. Patient portals, I certainly have seen an explosion in this, and especially messages back and forth after the pandemic. Digital health. So a lot of, not all of my patients, but some are starting to experiment with digital health devices and wearables, produces a lot of data. So we have to figure out how we manage and incorporate that data into their healthcare. And then big data, lots of data coming in from multiple sources. How do we manage that? How do we analyze that? How do we interpret and apply those results? So a lot of changes in the practice environment, in addition to delivering high quality clinical care. So just to set the stage there a little bit. So in this 21 NASM report, this is a diagram from that report that depicts how the authors that amassed the evidence for this high quality primary care report conceptualize an interprofessional team, and they do so in sort of three buckets or three layers. The first being the core team, which are those labels that you see in purple, consisting of the patient and the family members as core members of that core team. Clinicians, so referring to physicians, nurse practitioners, physician assistants, nurses, clinical support staff, such as office managers and medical assistants. So those are the individuals that were named in this report as members of the core team of an interprofessional primary care team. I do want to say a couple of notes about family members and then separately about patients. Throughout my career, I've heard more and more attention being placed on the importance of engaging patients and family members as members of the care team and moving away from a paternalistic or maternalistic approach to healthcare and engaging more in shared decision-making with patients. It hasn't always been a smooth journey or smooth transition, but part of that is really engaging patients and family members in that care team. One of the reasons that I love thinking about family members as part of the care team is that they have intimate insights that we don't have into our patients' backgrounds, their history, their typical functional status and capabilities, and their life circumstances, and often hold a really valuable perspective on patients' ability to self-manage their conditions and to participate in ongoing treatment and recovery. So what they have to say is really important. And in terms of patients, in my experience today in my career, we haven't often employed a human-centered design approach to healthcare that places patients and their needs in the center of what we do and how we serve. And this can especially leave disadvantaged populations, further behind because of limited health literacy, mistrust of the healthcare system, and the legacy of institutional racism. So having patients as members of that care team and trying to reorient ourselves and center ourselves around patients, I think is a very, I appreciate that this report emphasized that concept. There's two other layers. So the next layer is the extended healthcare team, which you see here. I guess that's a teal color. And the members of this layer of the healthcare team can include community health workers, pharmacists, dentists, social workers, therapists of various types. So physical, occupational, and speech therapists, nutritionists, lactation consultants. So depending on the needs of the population that your team and your clinic are serving, you might have different health professionals that are part of that particular layer of an interprofessional care team. And then lastly, in orange is the extended community care team. And this may involve social support services, school-based healthy aging supports, places of worship, disability supports, home health aides, etc. So those resources in the broader community surrounding and linked to your clinic. So again, this is the framework for an interprofessional team as laid out in that 2021 NASEM report. So characteristics of high-performing primary care teams, what does that look like? One of the experts in this area that I appreciate is Dr. Christine Sinsky, and she's done a lot of research trying to identify practices where there's a great deal of joy in practice. And what does that look like? And what are the kinds of characteristics of those teams and of those clinics? And this is some of what she has found. The first being that high-performing primary care teams tend to be more proactive about care plans and anticipatory planning for patients that are coming in to the clinic. The care delivery functions are shared across the care team. Not all of those care delivery functions are the responsibility of one person. Number three is that administrative tasks, the examples that you see there, are also shared across the team. And that communication is prioritized through a variety of different channels with patients and families, and that team function is optimized. There's different ways to do this, whether it's huddles, mapping clinical workflows, and really understanding and identifying different roles for each member of the care team. So what does the evidence show thus far? There is increasing evidence that the interprofessional primary care teams are effective in the ways of moving toward achieving the quadruple aim. And you'll see that here on this slide in terms of improving quality, lowering costs, improving patient experience, and decreasing burnout, provided that clinical and administrative responsibilities are appropriately distributed across the team. So let's talk about the promise of interprofessional primary care teams. Whenever there's a new philosophy, a new thought about organizing, financing, and delivering primary care, there often are a lot of promises or potential benefits assigned to these new concepts. And so these are some of the promises that if you had a highly functioning primary care team, that they could help address these characteristics. The first being providing for authentic partnership with patients and family members as part of the care team. Number two, that collectively across that entire team, especially if you had behavioral health providers and lactation consultants, nutritionists, being able to provide a broader scope of services to your patients based on their needs. An interprofessional primary care team can increase the collective capacity to deliver on more comprehensive and continuous primary care services, may decrease provider burnout, fulfills the principles of community-oriented primary care, and is an opportunity to enhance diversity among the broader team to better match the communities being served. Community-oriented primary care, is that a concept that you have talked about or have been introduced to a little bit? Yeah. How would you describe it? Fantastic. Great. Wonderful. Good. Great. So wonderful examples. At a high level, it's sort of the thinking about the integration of primary care and public health and the intersectionality of that and what that allows us to provide more comprehensively to communities. Do you, in your program, rotate through the VA and several different settings? Okay. When you're at the VA, are you part of PACs or patient-aligned care teams? Officially or adjacent to that, or okay. Have you heard of PACs? A little bit, no? Okay. Let me walk through that a little bit, and because this is an example that many people point to as an example of a high-performing team in terms of how it's constructed and supported, the number of patients that team-led collectively takes care of. So patient-aligned care teams have been an innovation or advancement in the VA over the past few years. These teams are built on the concept of the patient-centered medical home with the goal of delivering whole health services. So not just providing for physical health, but also providing for mental, emotional, behavioral health, addressing spiritual concerns, any of those concerns that social needs that a patient brings to the table. So really taking a whole health approach. Teamlets, as they refer to them, consist of these individuals: the primary care provider, a PA or a nurse practitioner, the RN case manager, a licensed practical nurse or medical assistant, and an administrative clerk. So that's the unit that works together as a team to care for a panel of up to 1,200 vets as part of that PACT team. A PACT team emphasizes coordinated care through collaboration and defined roles and prioritizes patient preferences for her or his care. Veterans can access care from their PACT team in a variety of different ways. Certainly can come in person. There's also 24/7 care by phone if there is an emergency that arises at a time where clinics are not typically open. They can send secure messages and texts to their team and participate in group clinics and educational seminars. So a combination of personal touch, group touches as well with regard to a PACT. Thus far from the research, what we have seen is that PACTs have been associated with improvements in outcomes for patients with hypertension, diabetes, heart disease, other chronic illnesses. There have been decreases in emergency department use, especially if they're able to reach their PACT team, a decrease in inpatient hospitalizations and specialty care visits, and increases in mental health visits within the primary care team, which means that that PACT team is able to manage a lot of mental, emotional, behavioral health concerns within that team, as opposed to additionally needing to refer them outside of the PACT team. So the next couple slides, we'll talk about structuring primary care teams, how we might think about that, how we might think about financing primary care teams, and what supports primary care teams may need. When I think of structuring primary care teams, I think about this in two buckets. The first being composition and function, and the second being the size of the team serving a patient population. So when it comes to composition and function, important to think through what are the different types of health and healthcare professionals that you may need based on the demographics of the people you're serving, the local population health needs, community assets. Also want to think about establishing clear roles, workflows, expectations, and accountability, so everyone knows the scope of what everyone else on that team is doing. Distributing tasks and functions across the team, and depending on the team, depending on the patient population, this may be distributing these tasks and functions among clinical and non-clinical team members, among licensed and non-licensed health professionals as well. Important to plan for stability in that team. Primary care, when it works well, has a longitudinal relationship component. In years past, it has often been a relationship with one person. So how do we transition that to thinking about creating relationships with a team as opposed to that responsibility being entirely on one individual? Stability is important, not just for how that team functions together, but also important for those relationships between the team and patients and family members. And then also important to build a cohesive culture within that team. When I think of culture, when it comes to primary care teams, this relates to, how does that team function and value each other's contributions? How does a team create relationships with each other and with patients? And how does the team live or fulfill its mission? Size. So how many people do you need to care for your population as you have defined it? And it's often that answer of two words, it depends. So some of those reasons that it depends on the availability of health professionals and sort of the adequacy of the community supports that you have in your community. There are different ways, as you see listed here, to think about empanelment. So what patients do you assign to which teams? And you could benchmark this based on what panel sizes a clinic has had in the past, or doing what we call time-based studies to get a better sense of how long do important primary care tasks take, whether that's related to administrative needs that patients have, education, right? Those things take time. So what does that look like? And what does that mean in terms of the number of patients that you can realistically serve in a high quality way? And how many folks do you need on your team to do that? Other ways to think about size include geography and current care patterns and relationships. So as it was mentioned in my introduction, and thank you again, Dr. Shi, that I currently serve as co-chair of the Standing Committee on Primary Care within the National Academies of Sciences, Engineering, and Medicine. And I'll speak more to this later during my talk. But for now, it's important to know that this past summer, subgroups of the Standing Committee have responded to two RFI, request for information opportunities from the federal government, specifically about new ways of paying for primary care services that address payment in a team environment. The first, the one that has the purple cover, was a response to a proposed legislation proposed by Senators Whitehouse and Cassidy in the Senate that essentially suggested through legislation a more comprehensive hybrid payment for primary care that combines some fee-for-service elements with more of a sort of global per member per month type of payment that would address some of the education needs, care coordination, communication pieces behind the scenes that are often not accounted for when we think about the important work of primary care. And so we had the opportunity to comment on that RFI. The one on the right is related to a response to questions from the Centers for Medicare and Medicaid Services and their proposed rules for what's called the physician fee schedule for next calendar year. And this stuff gets pretty wonky pretty quickly, but every year CMS proposes and releases to the public, this is how we're thinking of evolving payment for different types of physician services. This year, those of us that are paying attention to primary care policy and payment reform, we're excited to see that the proposed rules for next year also have some proposed changes for more robust payments for all that extra primary care work that we do that doesn't readily have a particular billing code associated with it. So exciting, wonky stuff, if you like this and you track on this stuff. But seeing the take-home point from the slide is that we're starting to see some federal payment policy changes that I'm hoping will be more supportive of primary care teams moving forward. So how otherwise would we support primary care teams? In terms of the policy level, since I was just talking about that, I'll start there first and then come back to the practice level. We need to think about how are we going to finance and approach infrastructure. This could be everything from the bricks and mortar. Where is a team actually at when you're caring for patients when they're coming into clinic? Maybe some of that infrastructure is related to broadband or digital health needs. Maybe some of that infrastructure is related to technical assistance to help a primary care clinic if they want to do a better job at integrating behavioral health into their clinic. How do you adapt workflows to be able to do that, right? So having some practice facilitation or technical assistance to help with that. All of that, in my mind, I kind of put under the bucket of infrastructure. So how are we going to pay for those services or finance that infrastructure? Also paying for services, which I was just kind of touching upon the previous slide. I'll put a pin in scope of practice issues because we'll come back to that. All states vary in terms of their state laws and regulations relative to what can nurse practitioners do as part of a primary care team? What can physician assistants do as a part of a primary care team? Does there have to be a supervising relationship between those professionals and a physician? So it's a very heterogeneous policy environment, but paying attention to those scope of practice changes and evolutions is important when we think about trying to match demand for primary care services with existing need. And then examining our training models. I have a few slides where I'll talk about this. So I'll just put a pin in that one as well. When it comes to supporting primary care practice at the front line with making these transitions, I'm excited about a potential model that has emerged that may support primary care practices in making these kinds of changes toward more of a team-based care environment. Last Thursday I was in DC, or Rockville, Maryland, technically, not exactly DC, but close by, at the Agency for Healthcare Research and Quality, listening to report outs from different state recipients of grants that have been building what's called a cooperative. Is anyone from a rural area familiar with like extension, land grant universities and extension services, extension agents? Is that around? Okay. Oh gosh, sorry. I grew up in rural Iowa. So I was the 4-H kid. My dad still farms, and I went to a land grant university, Iowa State. And through land grant universities, they have these programs called cooperative extension, where you have experts scientifically in different areas. Could be farming practices, for example, that work in different counties in a state. And so if citizens have questions about how to improve X, Y, or Z, say farming practice, those extension agents would go and essentially provide technical assistance. I grew up watching extension agents come to our farm and help my dad figure out how to do rotational grazing that he wanted to do with our beef cattle. We'll go into what that is. That's not pertinent to today's topic, but I will say that observing those extension agents that are keeping up with the latest science from the university, it's a way for them to provide that directly to citizens. And so colleagues of mine with the Affordable Care Act, when it was being drafted in 2010, wrote language that created a primary care extension service based on that model of agricultural cooperative extension, which the Agricultural Cooperative Extension Service has been in place for well over a century. So we have some experience as to how this works. And so it was thought, could there be some translatable skills that primary care extension agents could use to help primary care practices transform and become even more effective at delivering high quality primary care? And so, like many things that Congress does, this entity to have a primary care extension service exists in statute. So it has been authorized. It's a real thing. What it doesn't have is money. It has not had any dollars appropriated to it. So until such time as there is money in our federal budget to support a primary care extension service, ARC, as a federal agency within the U.S. Department of Health and Human Services, has been issuing sort of smaller grant programs to gain experience with how do you set up and run and evaluate state-based healthcare cooperative extension services. And so that was the policy meeting that I was at in attending last Thursday and learning about the latest round and what they're doing and what they're learning. And I think that that has promise for helping primary care practices transform moving forward. So let me talk about this slide, ecology of healthcare. As I shared this morning when I gave this same talk, that this is one of my favorite diagrams ever, and you'll understand why. So colleagues of mine at the Robert Graham Center did an analysis to understand if you would take a hypothetical population of 1,000 individuals and 800 of those might report or experience, symptoms in any given year, where are they going to seek care? And let me make this a little bit bigger because it's about a size 2 font on my screen. Please give me 1 second here. Okay, so 800 report symptoms, okay, in any given year. 327 might be motivated enough or consider seeking health care, medical care. 217 would go to a physician's office, and it's estimated 113 would visit a primary care doctor's office. Okay? 65 might visit a complementary or alternative medicine provider. 21 would go to a hospital-based outpatient clinic. 3.4 would receive home healthcare services. 1.3 or 13, excuse me. Oh, 4, there we go. Sorry, it is so small. I apologize. Okay, you can read this better than I can. Let me just do this. 14 would receive home health care. 13 would go to an emergency department. 8 would be hospitalized, and fewer than 1 individual will be hospitalized in an academic medical center. The reason that I really like this diagram, especially when I can read read the words and the numbers on the slide, is that it gives us a sense of where our patients are, going to seek different services, right? And we are here at an academic medical center where a vast majority of graduate medical education dollars flow for training. Does that match where our patients are getting services or typically seeking care? So that's the mismatch that that I see, that I think is important from a policy perspective. So how would we evolve our approach to training primary care teams? These are some suggestions that were put forth in that 2021 NASM report. Early and sustained experiential learning in teams is important at different levels of your training. That team-based care should include core competencies such as communication, collaboration. How do you delineate and define roles, thinking about leadership, advocacy, some of the different skills? How do you identify community needs and expectations? And how do you do that in collaboration with your colleagues on that primary care team? How do you map and understand community assets and challenges, as well as how local systems of care are organized? How do you approach that? How do you do that? In addition to those sort of team-based care skills, it's also important for that team to collaboratively learn how to provide preventive care, counseling, how to manage a range of medical problems, and how to link patients and families to different care settings and services. Fully acknowledge this recommendation from the 2021 report is a super, super tall order, right? When you guys think back to medical school, was there any extra room for anything else? Nope, I'm not seeing a lot of heads nodding up and down, right? So not a whole lot of room for other things in the curriculum. And there's always a tussle as to, should this biochemistry lecture take the place of a lecture about Medicare and Medicaid or whatever the case is? These were some of the challenges that I witnessed my faculty have at the University of Iowa back in the day. There's also the physical space concern. If you are moving from training just a physician to a team, a primary care team, some of our clinics may not, like my clinic where I practice at a federally qualified health center, there isn't enough physical space to accommodate even a small team in terms of educational purposes. And as we, think about and plan for and make these transitions to interprofessional primary care teams, where are there exemplars? And are there enough of those that learners and teams can rotate with and learn those skills? The other challenge right now is that current funding streams are inconsistent and insufficient to support team training or to support different members of that primary care team. As I mentioned on that ecology of care slide, graduate medical education and children's hospital, GME, that's the CHGME, that funding is often directed to hospitals, not to community-based sites where patients in a community would typically receive or seek primary care services. Right now, there is not federal training or federal funding, that exists for training community health workers or medical assistants. There is also not consistent federal funding or support for educating nurse practitioners, physician assistants, or certified nurse midwives as other members of that primary care team. I'll come back to the GNE or the Graduate Nurse Education Demonstration in just a second. And HRSA, Health Resources and Services Administration. Has anyone heard of HRSA, federal agency within HHS? Okay, so one hand or two. Okay, so HRSA is an agency within the Health and Human Services that runs a lot of different health professional training and diversity programs. And one of the challenges that this agency has is that a lot of its funding for these programs is discretionary versus mandatory. When I use those words, does that resonate? Discretionary funding versus mandatory funding? A couple of heads. So mandatory programs are things like Medicare and Social Security. They will be funded every year. They do not require, through the congressional budget process, unique or specific approval every year. Discretionary funding does. And so for HRSA, running a lot of these different, say, nursing programs or dentistry programs or physician sort of training programs, every year advocates and those trainees are kind of holding their breath, being like, well, Congress, get its act together and pass a budget this year. And relative to some HRSA programs, I've seen that some of those programs have had to close or have chosen to close because of that funding variability and that uncertainty, which can be really, really difficult. The GNE demonstration program was made possible by language in the Affordable Care Act. This program is not currently active. It ended in 2019, but it was through the Centers for Medicare and Medicaid Services Innovation Center. That center was also established by the Affordable Care Act with the goal of innovating how we deliver and pay for healthcare services. And they initiated in the past decade a graduate nurse education demonstration program to essentially test the waters of, we have all these Medicare dollars that go into graduate medical education for physician training. Do we need to think about a parallel type of program for advanced practice nurses? And so that was an experiment that has been tried, not currently active. So let me shift a little bit to the National Academies for Sciences, Engineering, and Medicine, as I want to introduce to you briefly some of the work that I've been co-leading with the Standing Committee on Primary Care. The National Academies are private, nonprofit institutions that provide independent, objective analysis and advice to the nation to solve complex problems and to inform public policy decisions related to science, technology, and medicine. This is one of my favorite questions to ask, which is, when do you think the National Academies were established? Give me a decade. There are no, well, there is a right answer here, but there are no wrong guesses. How about that? 1880s. Okay. 1940s. What else? 1820. Okay, well, this is interesting. Okay, 1820, 1880s, 1980, and we had 1940s. Okay, Okay, raise your hand if you guessed the 1800s. I'm impressed. President Abraham Lincoln in the 1860s. All right. Yeah. Hey, yes. I mean, this surprised me too when I learned this. I mean, what incredible foresight. And so President Lincoln said, we're pretty smart in government, and there are a lot of incredibly smart folks and talented folks in government. I have worked with them, and I have been in government before. And the president said, you know what? We may have a need for external expertise to help us be better at governing and to make important decisions in government. And so the 1860s, during the Civil War, and he's setting up the national academies. Pretty cool. So that's one of my favorite latest facts that I've learned. Have any of you heard of the Institute of Medicine? Okay, a couple nods. So just a nomenclature issue. The Institute of Medicine was that name until 2015. Like many organizations that maybe you've been a part of, there was an organizational change and a shift and a new organizational chart. And now it is the Health and Medicine Division within the National Academies of Sciences, Engineering, and Medicine. So if you hear Institute of Medicine, equate it in your mind with the Health and Medicine Division within NASM. So just as a nomenclature issue. So in that 21 report on implementing high quality primary care, the fifth objective was to focus on accountability, essentially to ensure implementation of high quality primary care. Part of that recommendation, there was a call to establish two distinct entities or bodies. The first is a Secretary's Council on Primary Care in the federal government. So this was designed, the original idea as recommended in this NASM report was to have the heads of like the HRSA agency, maybe the head of Centers for Medicare and Medicaid Services, the head of the Office of Minority Health. So all these different agencies within HHS, the idea was to have those principals, so senior leaders, decision makers in those agencies, come together as a council to think about and make policy decisions about primary care. This does not exist in the way envisioned that was in the report, but 4 months after this report came out in May of 2021, Dr. Rachel Levine, who is the Assistant Secretary for Health, essentially the number 3 leader within our federal HHS, established the initiative to strengthen primary health care, which is kind of like a bridge to that interagency Secretary's Council on Primary Care. What is kind of remarkable, and maybe it's not, but I kind of find it a bit stunning, is that until the initiative to strengthen primary health care was established, there were not any federal leaders. There was not a specific federal agency that woke up every day thinking about the needs, opportunities, values, how to improve primary care in our federal government. Not a one. So this is the first one. So from a policy perspective, this is an important step in that direction. The other entity that the NASM report called upon was to create a primary care advisory committee, essentially a group of external experts in primary care policy, research, clinical care that could advise the federal government on various aspects of primary care policy. This also doesn't exist, the exact sort of letter of the recommendation in the NASM report, because this recommendation would require the involvement of Congress. Congress isn't exactly effective these days on a variety of levels. And to create a federal advisory committee requires congressional action and to include financial support for staffing such advisory committee in the budget. Within this statute called the Federal Advisory Committee Act, there is a special provision for the national academies where, in not having to rely on Congress, can set up an advisory committee. And if that advisory committee within the national academies follows particular procedures, the federal government can use the recommendations that that advisory group makes as if it had been a congressionally established federal advisory committee. Super wonky. Thanks for walking through that with me. But the Standing Committee on Primary Care that I have the honor of co-chairing is that entity within NASA. So we have to be very mindful about following protocol so that HHS could use our recommendations if they would so choose to do that. So our statement of task, what do we do as a Standing Committee on Primary Care? In a nutshell, the 20 of us are tasked with providing guidance on a wide range of primary care policy issues to the federal government, predominantly Health and Human Services, but also USDA, the U.S. Department of Agriculture, and the Veterans Administration. How do we do our work? There are two primary work streams that are in the public domain. The first is to have public meetings, either in person or virtual, and the second is to write and publish publications that advise federal actions. We chose two areas of focus for this year as a standing committee. One was payment, one was workforce. The second was workforce. We're under no pretense that we will solve all these issues, in this first calendar year. These priorities may carry over to our second and third years of the standing committee, for which we currently have funding. There are 10 organizations that have made donations to the national academies to fund the Standing Committee on Primary Care work. Those dollars go to support staff time to staff the work that we do on the Standing Committee. My role, my co-chair's role, everyone that serves in the committee, we are all volunteers. And those dollars from those different organizations in primary care support staff time at the national academies to help us do this work. I want to highlight a particular session from our public meeting in May. The second day of this meeting was all focused on workforce, and we had a specific panel that was on the interprofessional primary care team. And this lady here is Administrator Carol Johnson. She heads the Health Resources and Services Administration. I mentioned them earlier in terms of a variety of federal programs that they have to support the primary care workforce. We are fortunate to have her join us for most of that second day focused on workforce, which federal leaders, it's kind of like trying to pin Jello to a wall to get them to come to a meeting and be there for a good while. So we were fortunate that she was with us for as long as she was. From this session, there were some important takeaways. I want to loop back to interprofessional primary care teams and share these insights from this second day of this public meeting. The first insight that was shared on the panel is that the patient is the most underutilized member of the primary care team. It's number one. Number two, primary care graduate medical education needs to be sustainable, socially accountable, and increasingly community-based, if you think back to that ecology of care model. The third major takeaway from this session was that the types of professionals on a primary care team should vary depending on patient and population health needs and local context. These teams require upfront investment to better support hiring, training, and ongoing quality improvement. So those were three key takeaways from that discussion. We also heard from Administrator Johnson and from the other federal leaders that were part of this panel and part of this day that they have specific research needs that they need help with to help them think through how are they going to consider payment changes to better support primary care teams. So Administrator Johnson turned to the standing committee and said, well, who are the right people to be on these teams? Should it be universal or universally the same, or should it vary based on the community that you're serving, right? She also asked us to help her think about training. How do you train teams versus training individuals? And what is the federal government's role in helping to fund and support training of primary care teams? She also asked us to think about how do we better pay for teams, the form of payment, the amount of payment, and how that payment flows to primary care teams. And also, what are data needs that primary care teams may have, especially to better connect patients and families with community and social services? So these are questions that she turned back to us. And as a standing committee, we are wrestling with how are we going to proceed with responding to those questions to get back to HRSA. Last couple of slides. This is some new research by my colleague, Dr. Deborah Cohen, who's at the Oregon Health and Sciences University. I'm honored to serve as an advisor to this particular study. But if you see from the first sentence there that in many ways digging into the operational details at 12 different primary care practices, what are the functions? What are the tasks? Who are the professionals that do these tasks? And how much does this cost per member per month to support the team to do this work? So Dr. Cohen is leading this, and this kind of information from these type of research studies will be really helpful to respond to questions that HRSA and other federal leaders have. So all this to say, if anything about interprofessional primary care teams is exciting to you, and you're interested in doing research in this area, your research will be highly policy relevant. There are other trends that are impacting expansion of primary care teams. This includes kind of the current pressures, I will say, that I feel in my primary care clinic to increase efficiencies rather than effectiveness of primary care necessarily. Really considering sort of widening income gaps between primary care and specialties and subspecialties, and what does this have on the impact on selection or choice of primary care as a career? Chronic under-resourcing of primary care infrastructure that has compounded over the decades. What does that mean moving forward? And I also mentioned some of the scope of practice landscape, and is that a way to examine those policies to increase access and capacity for patients that are seeking primary care services? And last but not least, earlier on in the talk, I mentioned Objective 3, which was to train primary care teams where people live and work, as from the NASM report. And that objective is broken down into these two primary actions. You can see them on the slide. Just for sake of time, I won't read through those, but you see that my assessment, there's no clear movement in red letters, right? So all that to say that this will be an active area of ongoing policy research and movement moving forward. And with that, I will say thank you. I appreciate the opportunity to be with you today, and happy to answer any questions about rotational grazing or cooperative extension, primary care, the standing committee, NASM, what it's like to do policy as a career while being a clinician. Happy to answer any of those questions, but thank you. Appreciate it. Yes, please. Yeah, absolutely. So two responses are, Dr. Shi. So the first is that there are new codes to fund community health workers. That was part of the 2024 physician fee schedule changes, and that would be through CMS. So one of the things that's important about the Centers for Medicare and Medicaid Services, because it's such a large payer for millions and millions of Americans, when Medicare makes payment policy changes, that often can be a signal for commercial payers to follow suit. And so the G codes to support community health workers are through CMS. The agency that is supporting the creation of primary care extension teams or healthcare cooperative extension teams is through AHRQ, the Agency for Healthcare Research and Quality, another division within Health and Human Services. Please go ahead. That's a great question. I would say my first foray and kind of interest in policy was when I served as an AmeriCorps volunteer in a federally qualified health center the year after I graduated from Iowa State University with my undergraduate training. I had never heard of federally qualified health centers. I'm an Iowa farm kid, grew up on a gravel road south of a town of 142 people. I had never been to Berkeley, California, which was quite the change for me to just pack up and move out there for the year. That year, I predominantly enrolled low-income children and families in Medi-Cal and Healthy Families, so California's Medicaid and their state children's health insurance programs. And I fell in love with urban underserved care. I fell in love with, we weren't calling it this then, but the social determinants of health and appreciating how that impacted my patients and their well-being. And I fell in love with identifying and solving problems with colleagues and other community-based organizations, which when I look at that now, that's policy work. But I didn't have a name for it then. I just knew I liked this kind of work. But I did decide based on my AmeriCorps year that I wanted to do public health training concurrent with medical school. I initially planned to do my MD and my MPH at the University of Iowa. I started the MPH program there. And then I became very involved with AMSA, the American Medical Student Association, in my first couple of years of medical school. Spent time in DC with that organization and fell in love with DC as the classroom to learn health policy. So I ultimately withdrew from the MPH program in Iowa and did my MPH between my third and fourth years, essentially medical school at George Washington University. And that's where I interned for Senator Harkin way back in the day. I mean, just last year, of course. So good. I know we're coming up on time. Any other questions? Okay. Well, certainly here is my email, my personal cell. I love health policy work. I love being a family physician, an active family physician clinician doing health policy work. And so if anything in policy at the state or the federal level is of interest to you, regardless of the issue or the topic matter, please reach out. Be happy to have a conversation with you and talk more about policy careers, what that looks like, the reality of that on the ground, and the very many ways that you can be engaged in policy. It doesn't have to be just government. I've done policy, and I'm doing it right now at an academic health center. I've done policy at a membership association, a foundation, a research policy think tank. So there's lots of different environments in which you can do policy work, as well as separately advocacy work. And as a note, policy and advocacy do overlap, but they're not one and the same. So do not confuse those. Okay? Thanks, guys. Oh, thank you.
Thank you so much.
Thank you.
It's a point from her. Lovely. Second day with your say, would you? The military background will have to stay pointy, but in that
Great.
Thank you so much.
Shamelessly. Yes. Yes. Oh, you're welcome. You're welcome.
Thank you, Dr. Hughes.
Yeah.
I appreciate you rolling with the punches on some of the technical stuff.